you all know that you are dealing with diabetes mellitus patient every day, and we are mainly main concern regarding the diabetes mellitus is the nephrology part, that is the damage of the kidney. So protecting the kidney from the attack of hyperglycemia, that is very important, because as I am treating many patients in my OPD, I have found there are so many patients, so many CKD patients or evolving kidney disease patients, they are coming, and the most important culprit is diabetes mellitus. So preventing the complications of diabetes mellitus is very important nowadays, and there are many researches are going on. So the new approach is SGLT2 inhibitor, namely Dapaglifozin, that may prevent the further progressions of kidney damage in diabetes mellitus patients. So here it is already written that Dapaglifozin is a potent and selective renal sodium glucose co-transporter inhibitor, and it inhibits mainly subtype 2 of the sodium glucose transport proteins, that is SGLT2 protein, which are responsible for at least 90% of the glucose reabsorptions in the kidney. Blocking the transport mechanism causes blood glucose to be eliminated through the urine, and it significantly reduces the glucose reabsorption and decreases serum glucose concentration in an insulin-independent manner. The decrease of glucose reabsorption by Dapaglifozin has also been associated with a reduction in the body weight. So they are rapidly absorbed from the GI tract into blood. That is a positive advantage, and where they bind to plasma proteins and circulate throughout the vascular tree with a half-life of 10 to 14 hours. The free drugs are filtered from plasma at the glomerulus, where they bind to the luminal membrane of the proximal tubule. The SGLT2 inhibitor bind to SGLT2 in the luminal membrane of early S1, S2 segments of the nephron, where they block of 60% of glucose reabsorption. Glucose that escapes reabsorption in the S1, S2 segment, that is the proximal segment, they are again reabsorbed by SGLT1 in S3, causing complete inhibition. The non-specific inhibitor, they bind the complete inhibitions of glucose absorption. So proximal tubule plays an important role in glucose hemostasis by salvaging glucose that would otherwise be excreted in the urine. In humans, approximately 180 gram glucose is reabsorbed each day by two transporters in the apical membrane of the proximal kidney tubule. SGLT2 in the early proximal tubule plays a dominant role, whereas SGLT1 in the late proximal providers a substantial reserve capacity. SGLT2 inhibitor Dapaglifozin is directly evidence that the drug acts on the apical membrane of the early proximal tubule after glomerular filtration, and then it is reabsorbed by the nephron back into blood. So look at the picture here. You can see the Dapaglifozin, that the blue colored SGLT2, that is SGLT2, that is present in the proximal tubule. And look, the Dapaglifozin and other SGLT2 inhibitors mainly blocks the SGLT2 so that the glucose reabsorption is hampered and glucose is excreted, whatever filtered, that is excreted through the urine. That's how the SGLT2 inhibitors act, by increasing glucose excretion, and thus they decrease the blood glucose level. So I have added this one because I want to show you that how hyperglycemia causing kidney damage. First of all, in diabetes mellitus, there are a lot of things happening inside the body in the microvascular level, and that's very complicated one. If we can solve out how these microvascular changes occur, and if we can stop the microvascular changes for progression, then we can definitely reduce retard the progressions of diabetic kidney disease. That can save life of many patients. That can also be helpful because cost benefit that we can also provide some good, better life to the patients also. So this is first hyperglycemia. There are some, you you see that renal hemodynamic changes. What are the hemodynamic changes? Because in diabetes we have found there are development of some growth factors. There namely IGF-1, TGF-beta, so many growth factors, VEGF. These growth factors act on the afferent arteriole. Just imagine the picture of nephron. There are afferent arteriole, then glomerulus, then efferent arteriole. So in diabetes mellitus, what efferent? So in diabetes mellitus, what happened? Look at the afferent arteriole. Due to the effect of these growth factors, the afferent arteriole undergoes dilatation. So afferent arteriole undergoes dilatation, and there are also some changes in the peritubular capillaries also. So what happened? Due to the dilatation of the afferent arteriole, more blood is coming to the glomerulus, but efferent arteriole is apparently constricted in comparison to afferent arteriole in diabetes. So due to the dilatation of afferent arteriole but constriction of efferent arteriole, there is rise of the pressure. There is intraglomerular pressure rise. That's causing more filtrations that causes glomerular hypertrophy, and at progression it leads to glomerular sclerosis. There is also activations of the RAS and renin-angiotensin-aldosterone system, and this renin-angiotensin-aldosterone system also their activations that promotes these vasodilatory mechanisms to happen. There are some protein called nephrin, like nephrin. There are so many proteins, but nephrin is one of the protein which controls the integrity of the renal system. Due to the rise of the renin-angiotensin-aldosterone system axis, this nephrin system they diminished due to inhibitory mechanisms, and due to the nephrin inhibitions, there are increased depositions of the collagen, type 4 collagen, that is bad one, that infiltrations of the collagen into the glomerular basement membrane, and there is also that leading to podocyte injury. You know that to maintain the proper filtration, the podocytes of the kidney maintains a vital role. If podocytes are itself damaged, so there are albuminuria. The albuminuria, more albumin is excreted through the urine, and it furthers, like vicious cycle, it furthers retard the kidney functions and progress. Thus, kidney impairment is going on more and more. There are also some ischemic and inflammatory changes because due to the development of the hyperglycemia, there are productions of the advanced glycogen product, and these incites the inflammatory mechanisms, and all disease systems had main role in the endothelial dysfunctions. So vascular endothelium plays an important role in maintaining the integrity. So due to the development of the ROS, that is oxidative stress, reactive oxygen species, the vascular systems are also impaired. So ultimately, due to the alterations of the hemodynamic changes, due to activations of the renin-angiotensin-aldosterone system axis, due to productions of inflammatory cells and its infiltrations, and due to oxidative stress, these four mechanisms that produce damage to the glomerulus, that produce damage to the tubules, and leading to glomerular hypertrophy, glomerular sclerosis, tubulo-interstitial fibrosis, tubular atrophy, mesangial cell expansions, extracellular matrix accumulation, and ultimately the kidney is going to fail. So keep it in mind, this picture is important because though it is the normal picture, but in diabetes mellitus, in diabetic kidney disease, afferent arteriole dilated, efferent arteriole constricted, so there is glomerular, intraglomerular pressure rise, more ultrafiltration, and there is also the proliferations of the peritubular capillaries that also further leading to absorptions of the more sodium and glucose. So these are the ultimate pathophysiological mechanisms of development of the diabetic kidney disease. But what we do through applications of SGLT2 inhibitor, that the SGLT2 inhibitor blocks the sodium glucose transporter.
So as it is blocking the sodium glucose transporter in the proximal tubule, what happens? The sodium and glucose, they are not absorbed, but rather they are released. And this is sensed by the macula densa that is present distal. As they are sensing, the more sodium is coming to the tubule, more glucose is coming to the tubule, then they block the afferent arteriole by tubuloglomerular feedback. And SGLT2 inhibitor is mainly acting through the tubuloglomerular feedback, and this by the tubulo, when there is natriuresis that is done by SGLT2 inhibitor, by the tubuloglomerular feedback, the afferent arteriole, they are constricted. That's how the glomerular pressure decreased due to the effect of SGLT2 inhibitor. And it also thus they retard the progression of albuminuria, retard the progression of kidney disease. But due to the effect of tubuloglomerular feedback causing the constriction of the afferent arteriole, the eGFR may rise due to the applications of SGLT2 inhibitor initially. So SGLT2 inhibitors only lower plasma glucose level by blocking reabsorptions of the filtered glucose, which falls as plasma levels fall. Of course, if the plasma levels, the presence of the glucose in urine, that indicates the presence of glucose in the blood. If there is high blood sugar level, glucose level will also increase in urine. So if blood glucose level fall, the urine glucose level also falls simultaneously. That's why they do not usually cause hypoglycemia in the absence of therapies that otherwise cause hypoglycemia. So SGLT2 inhibitors does not cause hypoglycemia itself. SGLT2 inhibitors have also been proposed as a possible treatment for patients with non-diabetic chronic kidney disease or with heart failure with reduced ejection fraction. So during cardiological discussion, probably doctor will focus on the cardiology part regarding the non-diabetic use of SGLT2 inhibitors in heart failure patients. So the suggested approach to use SGLT2 inhibitors, you can look at the slides, and it is written very clearly that it is not considered as initial therapy for a majority of patients with type 2 diabetes. If a patient came to you with first diagnosed as diabetes mellitus and you are starting SGLT2 inhibitor as monotherapy, then I think that it is not a good approach. So what are the indications? When to start SGLT2 inhibitors? Of course, there are some indications. In patients with overt atherosclerotic cardiovascular disease not reaching glycemic goals with metformin and lifestyle modifications, usually we start metformin or advise patients to make some lifestyle modifications. But if the patient is also having some atherosclerotic heart disease, ischemic heart disease, we may use SGLT2 inhibitor. That will be a novel approach. Then, in patients with heart failure not reaching glycemic goals with metformin and lifestyle modification. So again, after the atherosclerotic heart disease, the heart failure patients, we can also use SGLT2 inhibitors in diabetic cases when it is not controlled, diabetes is not controlled. The third indication, that is in patients with eGFR less than 90 ml per minute per 1.73 meters square, that is when the diabetes is being progressed and that is biting the kidney and leading to chronic kidney disease at earliest stage. Whenever you find the earliest chronic kidney disease, you have to stop its progression. That is important. So on that case, SGLT2 inhibitor can be used. The fourth one, as a third line agent in patients not meeting glycemic goals on 2 oral agents. The fifth one, as a third line agent, third line agent in patients not meeting glycemic goals on metformin and insulin therapy. As a second line agent in patients with inadequate glycemic control on metformin who are unwilling or unable to consider injection therapy and in whom weight gain and risk of hypoglycemia are a significant issue. So these are the 6 vital indications where we can use SGLT2 inhibitor, but not as monotherapy. Contraindications to use SGLT2 inhibitor. Of course, there are certain contraindications like type 1 diabetes, Type 2 diabetes with eGFR less than 45 in case of dapagliflozin or less than 30 in case of empagliflozin and canagliflozin. And third is if the person is having prior diabetes ketoacidosis. Whenever a patient comes to you with diabetes mellitus, you have to check for presence of microvascular and macrovascular complications. Because in type 2 diabetes, as we are dealing with mainly the adult patients, in type 2 diabetes, whenever patient comes, the onset of the disease often started 5 to 10 years back and it may be undiagnosed. So patient come to me, come to physician with diabetes mellitus, we at first glimpse we have to check the presence of kidney disease, presence of retinopathy, presence of heart disease, all of these. So we have to calculate the eGFR. If there is presence of kidney disease, kidney involvement, in presence of ischemic heart disease, we can certainly think about whether we can use the SGLT2 inhibitors. So these are the three contraindications. What are the avoid to use? That means the precautions. That frequent bacterial urinary tract infections or genitourinary yeast infections. The second one, low bone mineral density and high risk for fracture and falls. The third one, foot ulcerations, vascular disease or history of previous foot ulcerations. We have to be careful actually before prescribing these SGLT2 inhibitors, especially canagliflozin. Fourth one is factors predisposing to diabetic ketoacidosis. Like patient is having some pancreatic insufficiency or patient is alcoholic. On that cases, there are increased chances of diabetic ketoacidosis even in type 2. And you have to be very cautious regarding prescriptions to these patients. And cautiously use with ACE inhibitors, ARB, NSAIDs. Why? Because we often give ACE inhibitors or ARB to the diabetic kidney disease patient along with SGLT2 inhibitors. We can practice it also because we think that we have to prevent the albuminuria, but we have to be cautious also because ACE inhibitors, ARBs, and NSAIDs they have certain actions on the kidney that may precipitate the kidney injury, and SGLT2 inhibitors they also produce volume depletion. So by the combined effect of ACE inhibitors and SGLT2 inhibitors, AKI may be precipitated. There are some case reports. So dapagliflozin, my previous speaker already described it. Dapaglifozin 10 mg once daily can be taken any time of the day with or without food. It is not recommended for use in patients with active bladder cancer. Keep it in mind that active bladder cancer patients, we should not use dapagliflozin. There are some tumorigenesis associations found in case of dapagliflozin. So active bladder cancer, you have to take the history. For patients with severely reduced liver function, a starting dose of 5 mg is recommended. There is limited experience in patients with severe hepatic impairment. So the clinical outcomes. The glycemic efficacy, they are relatively weak glucose lowering agents because you cannot use the SGLT2 inhibitor as monotherapy I already described. Cardiovascular effects in patients with type 2 diabetes and heart failure, they all have beneficial effects. The DAPA, EMPA, canagliflozin, there are so many trials, and the Empiric trial, the DAPA-CKD trial, the CANVAS trial, all trials they produce, they showed there are positive cardiovascular effects. So cardiologists will describe it later on. And all SGLT2 inhibitors retard progressions of diabetic kidney disease, and they also decrease weight. So in case of obese patients, we can use certain. The adverse effect, of course, the increased chances of urine infections, urosepsis, pyelonephritis, necrotizing fasciitis of the perineum. So before prescribing it, ask the history whether the person is having recurrent history of UTI or past history of pyelonephritis. Ask the history, then give SGLT2 inhibitors. History of bladder cancer, especially in case of dapagliflozin, we found some association. Hypotension it can produce, but because it is volume depleting agent, and acute kidney injury I have already mentioned, especially if it is given along with ACE inhibitors or other nephrotoxic drugs like NSAIDs, and it increases chances of bony fracture. I don't know what what is the mechanisms of increased chances of bony fracture with SGLT2 inhibitors, but probably they have some effect on the electrolytes like calcium phosphate metabolism. That's why they increase the fragility. So that leads to bone fracture as well as amputations and increased chances of euglycemic ketoacidosis. That we are finding the patient is having ketoacidosis and the CBG level less than 250. We have to think about use of SGLT2 inhibitors. So this one I have already described. I don't think that to be discussed again. The chronic kidney disease. This is the burden of the chronic kidney disease is growing on. So you as a physicians, we all have to be very cautious regarding the use of Dapaglifozin and progression of kidney disease. So because the specific SGLT2 inhibitors used to treat patients with type 2 diabetes, only approximately 50% of total glucose absorptions. So forget it. These are the interpretations of the study I have already described. So I have already described it. So this is all of it's a clear glimpse that Dapaglifozin by promoting the sodium and glucose excretion, it is causing the vasoconstrictions of the afferent arteriole by the tubuloglomerular feedback, and it leads to decreased plasma glucose, decreased body weight, decreased blood pressure, decreased plasma uric acid, decreased glomerular hyperfiltration. So thank you all.